Good morning, everyone, esteemed colleagues and partners. Be welcome to today's side event at the 78th World Health Assembly, Data to Action, How Metrics and Standards Are Improving Patient Safety, sponsored by World Federation of Societies of Anesthesiologists and WFSA and CHESA. I'm Carolina Haylock-Lore, President-elect of the WFSA. And it's my privilege to moderate this important discussion. As nations work to enhance our health system for universal health coverage and improve emergency preparedness, the integration of emergency, critical, and operative care has become a vital strategy for reducing morbidity and mortality. Timely and coordinated care throughout this continuum is crucial for saving lives. Increasing evidence and data from clinical registries to operational metrics underscore the urgency and feasibility of establishing the integrated eco-services. Launched in 2024, the Acute Care Action Network, ACAN, serves as a platform, a global platform, to support this initiative by advocating for and facilitating integrated eco-service delivery. ACAN's mission is to enhance patient outcomes in emergency, critical, and operative care through cross-sector collaboration, data-driven decision-making, and practical implementation support for countries. Today, we'll explore how innovative data collection tools and techniques are transforming healthcare decision-making. Our session will focus on the critical role of metrics and standards in strengthening patient safety and integrating emergency, critical, and operative care into universal health coverage. Through insightful presentations and dynamic discussions, we'll uncover how these advancements are driving progress toward equitable, high-quality healthcare for all. Each of our panelists will have 7 minutes to give us their insights of proper organization, data collection tools and techniques. Q's and A's will be at the end of the meeting. So let's get started by introducing our first panelist, distinguished panelist, Dr. John Fogarty. John has more than 20 years of primary care experience in both high-low resource settings, and now serves as the lead for primary care services in the Department of Integrated Health Services at WHO headquarters. He is actively engaged in supporting countries in making progress toward universal health coverage through a primary healthcare approach. So hand over to you, John.
Thank you.
Thank you.
Thank you all. It is fantastic to be here with you. And I just want to take a moment to acknowledge all of you and your organizations that you're supporting WHO. It comes at a critical time. Some of you may have heard that WHO is going to be going through some changes in the coming months. And we are truly grateful for your support and expanding support. It means a lot to the organization, but it really means a lot to the staff that are working here, to know that so many of you are out there and have our backs. So thank you for being here. I'm going to, in 7 minutes, give you a speedy overview of what is called the Service Planning, Delivery, and Implementation Platform, affectionately known as the SPDI platform. So 7 minutes, I'm going to give you the overview. Just for some background, all countries are working to make progress towards universal health coverage, or UHC. And unfortunately, there has been a gap. Countries have stalled in their progress towards expanding on UHC. So about 5 years ago, 6 years ago, WHO received increasing number of requests to have support for UHC. And WHO launched a huge initiative to bring together 70 programs from across WHO to provide not only the technical advice on the list of services, but rather what are the things that a country would need to actually be able to implement a package of services. So what has been created with the input from more than 70 programs across WHO is a huge database of services, but also the material resources that a country would consider for a package, the products, the kits, the sets, the modules, the devices, the diagnostics that are needed, the medicines that are needed, as well as links to WHO references and guidance. So this is the SPDI platform, and I'm just going to give you, I don't have much time, and cursor is very small, so let me try to find it here. This is a SPDI platform that was developed. It's been used by more than 40 countries in the last 2 years, and it links to that massive database, and it also allows for a country to take a structured approach to building a package. And countries have been using it for many different purposes. For example, it's been used for humanitarian response packages. So Cox's Bazar just released a package last year. It's also been used for program-specific packages. About 10 countries came together to define a package of services for obesity. And then other countries are using it to define a national package of services. So for example, Jordan in 2023 worked to define a national UHC package, an essential health service package for UHC. And sorry, my cursor is very small. So this is, that's the Jordan. It's so small, I can't even see that it's, which package is it? Sorry, let me just go here. So I'm going to show you the Jordan package from 2023, universal health coverage. The SPDI platform uses a structured architecture to allow countries to go systematically through all health areas. So it includes foundations of care, so services for emergency care, emergency syndromes, sexual and reproductive health, growth, development, and aging, including palliative care services, NCDs, mental health, injury, communicable diseases. And as you go further into the architecture, it allows countries to get more detailed information. So for example, for non-communicable diseases, there's an extensive list of services for NCDs, which are oftentimes missing from packages of services. I'm just going to show you an example for cancers. This is again, the Jordan package. If I go into one of the areas, cervical cancer, you'll see that there are services for the detection and diagnosis and staging of cervical cancer, management of pre-invasive disease, management of cervical cancer. So on the left-hand side, you can see the list of actions or services. And then on the right-hand side are context-specific delivery platforms. So the levels of the health system in Jordan where they deliver services, from the primary care level to the 3 levels of hospitals. And one of the things you might notice here, the services, most of the services were mapped at the high level to the 2nd and 3rd referral level, even for, say, cryotherapy. What Jordan did is they took this information back and said, we need to slide those services back to primary care. And so they're working on developing a primary care package. The other thing I want to highlight here is in the back end, there are increasing levels of detail. So, for example, I just opened hysterectomy, which you can see there's information about the health workers that would be required to deliver the services, including, say, administer general anesthesia. Then there's information on the medical devices. So there's links to WHO's medical PACS database, Medivis medical devices database, the essential diagnostics list, the essential medicines list. So all of that is available to the countries. And then if you open some of the PACS, you can see a direct link to WHO's MetaPACS. So for example, this is the general anesthesia consumable kit, and you can see links to the specific devices that they would need to be able to provide anesthesia. I'm going to, since I only have 7 minutes, I'm going to show you one other thing. I'm just going to jump over to another package. I'm going to show you that Kyrgyzstan worked over the past year to define a package of services for universal health coverage. And my cursor, which has gone away. go. So Kyrgyzstan worked to develop a national package for universal health coverage. And like Jordan, what they found was that there was services were mapped primarily at the hospital level. So they're working to slide services to the primary care level. I'm going to show you an example with palliative care. There's a well-developed section for palliative care in the SPDI platform. And the SPDI platform allows you also, a country, to be able to identify the references, or if there's a reference package. So for example, I'm turning on a reference package. WHO has just developed a palliative care reference filter. It allows a country to turn on a reference filter to see where those services might be delivered. So in this example, management of common symptoms in palliative care, you can see Jordan is now focusing on delivering services at the community, outpatient, and first-level hospitals, and they've mapped those services for palliative care to their context-specific delivery platforms. And then you can see here with this little score, a reference filter. So for example, the WHO palliative care reference filters recommending if a country has the capacity to deliver oral opioids at the outpatient level, they might consider it. You can see Jordan said, we're doing it first at the first level hospital. We may consider it elsewhere. So this is a really powerful tool. We would be very pleased to do a deeper dive for your organizations if you're working with countries around national service planning. Again, we are working to build this both for universal health coverage, but also for humanitarian response, and then program-specific packages. So for palliative care is one example, but it also could be used for, say, operative care services if a country wants to scale services for operative care. So look forward to working with you. And again, thank you for being here. Very grateful.
Wow, that was quick. No, not at all. Thank you very much. Thank you. Thank you. Thank you for giving us an overview of universal health coverage service package delivery and implementation. And now let's hear from the other John Rose, on refinement and surgical indicators. John Rose is a plastic and reconstructive surgeon whose research has been done in the healthcare performance on healthcare systems, epidemiologic and facility-based data. His research findings have been featured in landmark initiatives such as the Lancet Commission in Global Surgery, Utstein Surgical Metrics Themes, World Bank Disease Control Priorities. Dr. John Rose, the floor is yours.
Great. All right, thank you so much to the panel organizers and to Carolina for the opportunity to present today. My name is John Rose. I'm from the CHESA program at UCSF in California, and I'll be talking about tools for impact and evidence. So I have a few disclosures just from groups that support my work. And by way of an outline, I'll talk about some of the validated preoperative metrics that we have that most of us are familiar with. The SData tool that we developed in Mozambique to accelerate the development of our surgical data ecosystem, and then why it matters. So we're all at this point familiar with 6815 and the call for measures or metrics of safe emergency and essential surgery and anesthesia, and how this was reinforced in the eco resolution later in 762. We're also familiar with probably with the 6 Lancet Commission indicators from 2015, so I won't read through them, but it's worth mentioning that they were adopted from the Lancet into the human development indicators from the World Health Organization, as well as from the World Bank, and later modified through Utstein consensus to clarify a few technical aspects with regards to risk adjustment, metadata, and data sourcing. And from that time, it's already been highlighted this week that there's been pretty marvelous momentum, and we're excited about that momentum. This is a chart, a shout out to Greta Davis, who's one of my mentees, fellows at the CHESA program, who put together a graph of the cumulative number of countries that have reported surgical volume over the last 20 years, and it's rising, and that's great. However, some of the key issues are that 80 countries as of 2024 still have not reported surgical volume at the national level, and that only a handful of countries have ever reported twice. And so I'm as guilty as anybody. This is our report from data in 2015 from Mozambique, where I worked with the National Surgery Program within the ministry to report the Lancet Commission indicators from every hospital that performs surgery in Mozambique. So full disclosure, I'm a guilty party. But the real question is, how do we transition from these academic data sprints to sustainable data reporting that probably lie within the public sector and not within academia? So we created a tool to accelerate the development of health data ecosystems. According to ChatGPT, this is a complex network of stakeholders and technologies that support the creation, sharing, analysis, and use of health data to improve healthcare research and public health. Of course, the World Health Organization goes into much more detail in the Health Metrics Network volume on the topic, and they describe the virtuous circle through which better information can promote better decisions, which ultimately results in better health. And specifically from their framework, I want to highlight the levels of data collection that they use as a framework, where they talk about the patient level, the facility level, the district, national, and even global levels, and how the data elements and the data needs serve different purposes with each level. Specifically for the purpose of understanding a data ecosystem, we focused on the tools of how these are gathered, because those are what reinforce the standardization and categorization of the elements themselves. It's worth also mentioning that not all of this information can come from institution-based data alone. It has to also be balanced with population-level data sets. So for example, if we consider surgical volume that I already mentioned, the cases, of course, come from some facility-based data where it's performed. However, the denominator of that metric is, of course, the population. So this becomes complicated when we're talking about subcategories of or subspecialties of surgery where the denominator may not be the same. Within their framework, they also outline a phased approach to how to evaluate and also implement within the data ecosystem space. First, starting in phase one in the top left with, promised myself I would use the laser right here, with a multidisciplinary and multi-stakeholder analysis. And then after gathering people together, creating combined priorities and agendas, and then diving into the healthcare system itself. So we followed this algorithm. We convened a national stakeholder meeting in Mozambique. This is a picture from 2 years ago where we gathered individuals from various different walks of the bureaucratic system as well as the clinical system. And we discussed all the indicators, metadata, IT, analytic tools, oversight, management protocols, and of course, the implications for the public's health. And we developed a survey tool based out of all that information. It's a couple pages long, so I'm not going to go through every element, but it builds off of what's available in the PGSSC surgical assessment tool, which focuses mostly on the hospital survey. And then it goes into a ministry level where we ask questions about protocols and what metadata exists and how that data is managed, stored, the custodianship of it with regards to ethics, and also how it's ultimately fed back to the providers themselves. And what we found is that this is a very brief diagram of the data ecosystem. That at the individual facility level, each facility gathered and created data for its facility report from the patient charts that they treated. However, flexibility was built into the system so that each hospital or facility could report from the patients that they see most commonly. That's great for flexibility, but what it means at the facility level is that now the data are no longer comparable because they're each reporting different data. That heterogeneity is then perpetuated as those hospital level reports get amalgamated into district level reports, and then it passes on even further to the ministry, such that the data we have by the time we arrive at the ministry is largely either unintelligible or non-representative. We also found that there was a DHIS2 module that already existed within the healthcare data infrastructure. And it fed information directly from healthcare centers themselves straight to the ministry electronically. However, it was developed by a group of ophthalmologists and was restricted to only that topic. We also found that there was a hospital infection surveillance system for the entire country, such that any infection that occurred within any hospital was reported, and it had a flag if it was after surgery. But that data stream was isolated from any of the surgical data streams, such that you couldn't match a numerator with a denominator and understand what a surgical site infection rate was for any given type of surgery or even for all of the surgeries. And then we also found, amazingly, there was actually a manual of indicators within the ministry. It was a very long manual, and it had very detailed descriptions, metadata descriptions for 9 surgical indicators already in existence. However, the X worked. It was in the ministry and in the ministry alone. It was not being used, nor were any of its elements in any of the levels of the healthcare system for reporting. So this was the nature of the data ecosystem in Mozambique. And the question was, well, if we want to implement some kind of Lancet Commission indicators or Utstein modifications, where would we start and where would we end? So we developed a tool subsequently that allowed us to compare the elements from the Utstein consensus process with the presence or absence of those elements in that data ecosystem. And this gives us the ability to create a scoring card for each hospital. And here the facility level, the facility names are abbreviated for privacy a little bit. But you can calculate this at the facility level, the district level, the regional level, or even the national level. And importantly, it gives you not only the ability to decide yes or no, we have this data or we don't, but which data elements are we missing so that we can either integrate and or start a new line of data collection. Now, why does this matter? The reason it matters is because the ability to gather data in the 21st century greatly outpaces our ability to consolidate data. This is a picture or a diagram from a high-income country that tried to outline in one health system all of the electronic data resources that exist. The point I'm trying to make is that we find a similar concept now in low-income countries where, despite being in paper records, the same concept exists. There is too much data at this point to handle, and our job needs to be to consolidate and integrate instead of just adding more things to lists. The other reason it's important is because primary data is needed in modeling exercises. I'll take a little bit of a deviation here to go into what we're doing with the DCP4 on the COVID-19 response chapter, or volume, I should say. It's now known that between 2020 and 2021, in the first 2 years of the pandemic, that more people in the world died from non-COVID related causes than from COVID itself. I'll say that again. More people died from non-COVID related causes than from COVID itself. Here you can see all the excess deaths, and the red line is the ones that are attributable to COVID. And the 2/3 up here under the area under that curve is the non-COVID related deaths, which we attribute now to delays in routine healthcare, screenings, elective care. And that's led us, of course, to advocate for the development of healthcare systems with dual purpose interventions in mind. That is, things that help us to understand that pandemic preparedness must include the capacity to maintain non-pandemic healthcare, and that investments for upscaling should target these dual purpose interventions that strengthen both the yellow circle here as well as the green circle. Question, of course, for us in this room is, where does surgery and anesthesia lie? Is it concretely in the green? Is it concretely in the yellow? Or is it within that dual purpose area? I'm not going to waste time on this audience to try to convince you that it's in the pink, because I think we'll all agree on that. But what I will say is that these questions of what we should be doing at the level of healthcare systems and how we should be investing dollars are very important, but they're primarily based on modeling. So for example, early in the pandemic, the COVID Surge Group modeled that globally 14 million surgeries were canceled because of lockdowns during surges, and that those exacerbated acute on chronic backlogs for elective surgery. Now, I'm not going to get into their analysis, but what I am going to say is that their data was modeled off of surgery volume data at the national level, for which 120 countries were missing. This is another example from the Surgical Preparedness Index publication in the Lancet, where they looked at resilience models and tried to figure out what components of a surgical system would prepare us to deal with acute threats like a pandemic or some other kind of threat to the healthcare system. And only 4% of the hospitals with surgical volume data in this data set were from low-income countries. So if modeling exercises, which have to be done, by the way, and I've done plenty of them myself, if they're a part of decision-making at global levels, we need to increase the quality and amount of data that's going into those modeling exercises. So in summary, robust assessments of surgical data ecosystems facilitate implementation of perioperative metrics, the ones we all covet and champion. Ministries of health are critical partners for consolidating and integrating data sources, and that robust data ecosystems can facilitate both pandemic preparedness and universal health coverage by helping us understand systems level effects globally. Thanks so much.
Thank you very much, John. Great insights. Thank you for those valuable perspectives on surgical metrics. We want to thank all you for participating, all the attendees, but also our attendees by Zoom. They're connected right now. So thank you very much for being here, for joining. Continue on our focus on data-driven improvement. Next, we have Chris Dodgian that will discuss the Operative Encounter Registry, OER. Chris is an associate professor of trauma and acute care surgery at the Medical College of Wisconsin. He is a fellow of both the American College of Surgeons and the College of Surgeons of East, Central, and Southern Africa. His work focuses on surgical systems strengthening global health and health policy. Chris, please take it away.
Wonderful. Thank you very much to WFSA and CHESA for the pleasure to speak today. Now that John gave us a framework of how countries should think about or how should care be delivered and the packages and resources that may be required, and John gave us a picture of what the Utstein metrics look like and the morass of the difficulty of collecting global surgical data. I'm going to spend the next hour and a half or so going through how I think we should do it. So despite the existence of good quality improvement guidelines, such as WHO guidelines for trauma quality improvement programs, the countries lack the infrastructure to carry out these initiatives, as we heard from our previous speakers. This was highlighted in the passage of WHA 7216 in 2019, which specifically called for better data collection to support effective planning and resource allocation for emergency care. In response, the WHO launched the clinical registry platform, which I'll go through in the next few slides. It first started out as the International Registry for Trauma and Emergency Care. This helped characterize disease burden and standardized data collection and integrate data access across the continuum of care for pre-hospital and both the emergency room. The registry wasn't launched in isolation, however. Standard intake forms were a key component to the implementation. This allowed for a systematic and a structured approach to every patient that could be integrated into a regular clinical workflow, facilitating collection of these WHO registry data points, and the core variables of the data set are highlighted here in yellow. The trauma or injury data set was developed through a multi-year consensus process that led by the WHO's Global Alliance for the Care of the Injured and informed by the existing WHO guidelines for and minimum and extended data set was developed. And you can see sort of the laundry list of items that were in there. There was about 46 core variables and 28 extended variables. This was further expanded to the emergency care data set. This covered common emergency department presentations, including additional decision support variables, as well as variables to include pre-hospital and triage care. And they begun tracking patients in the early continuum of care, from the pre-hospital setting all the way through the emergency department. Just to step back a little bit, the WHO clinical registry platform was built on the freely available DHIS2 platform. It's open source, it's web and tablet based. It enables real-time case-based data collection that can be analyzed both at the facility and national levels. It includes automated dashboards and audit filters to help identify gaps in care and drive continuous quality improvement. The rapid availability of data and aggregated results facilitate a rapid cycle of quality improvement to early intervention and to allow for early intervention and targeted education, the immediacy of which helps increase the impact and value. Recent passage of WHA Resolution 76.2 continued the mandate for improved data collection and expanded across the entire patient journey from the emergency department through the operating room and into critical care. The next few slides, I'll focus on the WHO operative module, which is the most recent addition to the clinical registry The initial operative module includes 24 core variables that are listed here and highlighted in yellow. It captures key elements across patient registration, pre-op assessment, intraoperative interventions, and postoperative outcomes. These variables allow for identification of barriers to safe surgical care and monitor trends in surgical efficacy and quality. It was designed to be a minimum that could be collected at the district hospital level, wherever surgery was being provided. That's key to remember, that this is sort of the baseline of what we hope everybody will collect, rather than what we would ideally like to collect in a research study, for example, or if we had our ability to collect any data that we thought was important. This is really what we thought might be actionable and improve quality of care. Next, the extended variable data set included an additional 8 variables. Those are now highlighted in yellow, primarily focusing on payment, as well as different intraoperative monitoring or tracking delays to surgical care. Ultimately, there was actually, with the core and the extended data set, well, there's 24 variables in the core and 8 in the extended, only 12 are new variables to focus specifically on surgical care, meaning 12 are actually already in the emergency care module or trauma module, and then 4 in the extended set are new for the surgical data set. The advantage of the WHO registry is it provides dashboards and instant feedback. Facilities can monitor their own performance, while ministries of health can view national trends or run reports without needing any code, any statistics, or any data manipulation, and it's available instantly. That helps decrease the amount of delay to getting accurate information and be able to act on that accurate information to affect care. These visualizations make data understandable and actionable, and facilitates both planning as well as early accountability. Additionally, the modules include audit filters that are automated flags for possible preventable harm. This means death in ASA class 1 and 2, lack of pulse oximetry use, delays to surgery. Some of the audit filters in the operative module are shown here. These both trigger and facilitate a deep dive into the patient's chart to examine opportunities to improve quality through re-education, facilitation of obtaining additional supplies that may be missing, or updating various processes. Another unique thing about the operative module and the G4 Alliance is that it includes a community of practice. Community practice is a virtual case-based learning network that brings together providers, in this instance, data collectors and experts, to engage in real-time problem solving and shared learning and capacity building. This will strengthen both implementation and sustainability. We're just about to pilot both the community of practice as well as the Operative Encounter Registry this summer. So the WHA Resolution 6815, 72.16, and 76.2 all emphasize the need for high-quality, standardized data collection to improve patient safety and strengthen the eco-care systems. The WHO Clinical Registry, I would argue, directly supports these goals by providing a unified, real-time platform for quality improvement, data-driven planning, and health system resilience. It's important to remember, only what gets measured can get improved. Through standardized, actionable data, we can achieve safer, more equitable emergency and critical and operative care. This type of project doesn't happen without a whole boatload of people in tiny writing, so you can't read their names. I also want to mention that I will go into more detail, or a number of us will go into more detail tomorrow of the Operative Encounter Registry. It's an aside event that's happening tomorrow afternoon. If you're interested in attending, you can register by scanning that QR code. Thanks very much.
Thank you, Chris. Your discussion on data collection sets the stage for our next speaker, Professor Gelb will share how the Anesthesia Facility Assessment Tool, AFAT, measures anesthesia and anesthesia service capacity. Professor Adrian Gelb is a distinguished professor of anesthesia and perioperative care at the University of California, San Francisco, He is past the president of the World Federation of Societies of Anesthesiologists, WFSA, and has worked extensively on global health and health system strengthening. His research advocacy focused on improving access to safe anesthesia and surgery worldwide. Adrian, the stage is yours.
Do I just use this to pull up my slide? Great. Thank you very much. Great to see all of you in the room. Thank you very much for supporting our event. My email address was on the version that I submitted. I suspect my black print on a white background has somehow become a blue background, but you're welcome to contact me should you have any interest. By way of disclosures, none of them are relevant other than a little Canadian flag at the bottom because I'm a Canadian. There's plenty of evidence that guidelines and standards improve outcome. This is a meta-analysis published a year or two ago. The green bars showed the number of studies of these various outcomes. Blue indicates improved outcome, and dark brown color, a worsening of outcome. And you can see there's virtually no evidence for worsening. Some studies didn't find huge changes, but the vast majority, I think, have found an improvement. So I think it's safe to go forward believing that standards and guidelines, if they're adhered to, will improve patient outcome. And with that in mind, we decided that there was a need for an international set of minimum standards. This sets the ground floor, not the maximum, not the optimal. The focus was really what is, if you will, the minimum, and then some suggested options for building above that. And it was a joint project between WFSA and the WHO. Reasons for having standards of care are sort of intuitively obvious. They establish acceptable levels of performance. They create consistency. They create an understanding that patients everywhere, if they're international standards, should expect the same level of care, independent of what country they are in. The same standard should apply to all care delivery cadres. Doesn't differ whether you're an anesthetic assistant, a physician anesthesiologist, a nurse anesthetist, or whatever. Same standard of patient care. I strongly believe that one of the benefits of standards of care is the political tool they provide for those of us who are politically active. They allow one to go to ministries of health and say, there's a standard of care, in this case has the WHO imprimatur on it. We are not meeting this standard. And I think the appeal to hospitals is that it creates some standardization of care and therefore some efficiencies. Now, anesthesia is commonly regarded as one of the pioneers in patient safety. That goes back to the recognition of anesthesia in the Institute of Medicine's publication To Err is Human, work done in 1999 and 2000. This is a quote from that IOM document. And these are the statistics in that document, that anesthesia had moved from 2 deaths per 10,000 to approximately 1 death per 200,000. So we've made a dramatic improvement. That doesn't mean that we should stop trying to improve further. We shouldn't just rest on our laurels, but a dramatic change over a relatively short time period. And so that begs the question, so how did this happen? It wasn't like we were sitting around in the coffee room, we got tired of complaining about surgeons and said, well, why don't we fix patient safety now that we fixed all of our surgical colleagues? It came from the public perception, this is from ABC television in the United States, their 2020 program in investigative journalism. This is in 1982, and this is their exact headline for an investigation into how dangerous is anesthesia. That anesthesia is inherently dangerous should come as no surprise when you think about state-sanctioned execution. What do states who execute people do? It's an anesthetic induction. They use our medications. They just overdose it a little more than we do, and they forget to put in an endotracheal tube. But otherwise, it's exactly the same. The other related event at that time was that a leadership group for the hospital, the Harvard-affiliated hospitals, Mass General, Brigham, and the like, noted that anesthesiologists were 3% of the physicians, but accounted for 11% of malpractice suits. So they did what every smart institution does. They appointed a committee. This happened to be a particularly talented committee, and I'm not sure if it was deliberate or not, but the committee actually included engineers. It wasn't just a group of anesthesiologists. Jeff Cooper is an engineer. Jeff is still around. Jim Phillip is an engineer and an anesthesiologist. And so it brought together, by default, a multidisciplinary team. They spent a couple of years looking at the problem, and they came to the conclusion there are no standards of care in anesthesia. In fact, there were no standards of care in any aspect of medicines. Whatever the practitioner determined was right, was right. And as engineers, they said, you know, we could fix 70% of these things with a set of standards, as we have in engineering, and with technology. And so they published what I believe is likely the very first set of standards for patient care. This was in 1984, and I believe in that they coined the term patient safety, was the first use of those two words together. And you can see the huge impact that it had on outcome from anesthesia. This is data from a little over 10 years ago from Janet Martin and Dan Bainbridge. But you can see in high-income countries this dramatic reduction in anesthesia contribution to mortality and morbidity. In the orange-colored sort of line, you can see in low-resource settings, there's a trend as they implement and do more surgery with anesthesia to an opportunity for catch-up. And one can ascribe that to standards, training, and equipment. And so we took those international standards for the safe practice of anesthesia and turned it into a checklist, so that not only they set the standard, but we created a tool that can be used to assess your operating room, your perioperative services. Under these headings, I'm not going to take you through all of the headings, but they're the sort of standard aspects of care in the perioperative ecosystem. How has our anesthetic facility assessment tool been used? And it is freely available on the WFSA website. And if you go to the website, you'll see that our UCSF CHESA group are willing to make our REDCap account freely available for anybody who wants to use our account for their data collection. We're willing to do some limited data analysis for you and return it to you. So there have been 8 published studies, 5 countries, 318 hospitals. I'm aware of 2 additional unpublished studies in India and in Guatemala, Nicaragua. And there have been a number of modified versions, particularly through COVID, that were a little more focused on the critical care aspect, a little less on the intraoperative aspect, that was used, to our knowledge, in 40 countries, over 700 facilities. We have the data, but we cannot legally use any of it because the data belongs to the hospitals, not to us, which is really frustrating. because there's a lot of interesting information in that. We've found from those that the common shortfalls are workforce, medications, analgesics, and oxygen. No real surprise there, but lots of confirmatory evidence. We're just completed an update and some revision to the AFAT tool. We'll be pilot testing it in Uganda and in Khartoum. All 27 hospitals in Khartoum, assuming the rebels don't destroy them, have agreed to participate in a pilot use of this tool. I do want to acknowledge Ronald Bisagewa, who's an anesthesiologist in Kampala in Uganda, who worked with myself, my colleague Michael Lipnick, on this project. So in summary, standards guidelines have demonstrated improved outcomes. When you go back to whatever clinical service you may be from, follow the guidelines. The evidence suggests that almost 60% of us work around them. Standards should be integrated into healthcare policies. Anesthesia has been a leader in standards for care and advocacy for patient safety. Assessment of the ability to meet standards requires data, which is what we're here to talk about. AFAT provides a comprehensive, very comprehensive anesthetic assessment tool, way beyond the sort of, can you do general anesthesia, can you do spinal, which is the sort of standard surgical approach to anesthesia. We can talk about a modular version during the discussion if there's interested. Thank you very much.
Thanks, Adrian. Your insights into assessing anesthesia services provide a perfect segue to Karima, who will present the findings from the African illness, critical illness outcomes study, ACOs. Karima Khalid. Karima is a lecturer and senior consultant at Muhimbili University of Health and Allied Science, with experience in critical care, anesthesia health systems, research, and policy engagement. She serves in the WFSA's Critical Care Committee, Connexus Education and Scientific Committee, and is one of the regional directors of Vital Anesthesia Simulation Training, VAST. She is currently leading implementation of EECC in Tanzania. Karima, I'll pass it over to you.
Thank you for this great, thank you. Thank you for all the great speakers who've spoken before me. And as a last speaker, I'd like to take you through the African critical illness outcome study that was done across Africa. And maybe to start with, I can say for many years, those of us working in the lower and middle income countries have been frustrated with the outcomes of our patients. Sometimes work so hard in our areas of work, in the emergency, in the theaters, ICUs, and our patients end up either dying or becoming very sick in the wards where care needs to continue for them. And we didn't have a lot of data showing us what the burden looks like in these countries. And most of the data that we had was from other sources globally, but not from Africa, mostly from the higher income countries. So together, for us to understand first how the burden is, or what we're talking about when we talk about critical illness, we would like to just define what we mean by critical illness. And because there's a lot of confusion between critical illness and how it's defined. So this is how we define it. It's a critical illness, the state of ill health with vital organ dysfunction, high risk of imminent death if care is not provided, and there's a potential for reversibility. So this can affect any age group, from neonates to adults, mothers, children, and even the very old people. So when we're defining this, we're talking about the illness severity. So any patient from any vertical group that we take care of, for example, the maternal care, the non-communicable diseases, surgical patients, at any point can become critically ill. And what these patients present with are actually mostly the same problems. So they have a respiratory problem, air problem, or a circulatory problem. And as you can see here, so any of these conditions can lead to critical illness. So how do we see, how is the burden of critical illness currently? What we've seen before is that we had a lot of data or some data about critical illness, but it was mostly driven by high income country data and also from ICU. So what we really need to understand is that when you talk about critical care, or we're defining the care that these patients need as a very to keep their vital organ functioning and to save their lives, and not advanced care that it's needed or provided in ICUs. So what we found from studies that were done previously is that around 45 million adults are critically ill, and around 11 million annual deaths occur due to sepsis. We also had some data from emergency units in Tanzania that showed 1 in 10 patients present to the emergency unit who are critically ill. And that mortality was really high, around up to in some places from 21 to up to 82% of these patients who are dying. So we wanted to find out from our own data, we wanted to generate data from Africa that will actually guide our solutions, context-specific solutions that we can use within our context that would save patients who are critically ill. So for us to come up with the solutions, we needed the data. So the Uprise group, which is African Partnership for Operative and Critical Care Research, together with ECC Global, came up with devised this study, which is the African Critical Illness Outcome Study, that was done across 22 countries and involved around 180 facilities or hospitals, and almost 20,000 patients were included in the study. And what we're looking at is what is the prevalence of critical illness and also their 7-day outcomes of these patients. We also looked at, as a secondary outcome, provision of critical care and availability of resources for the provision of the critical care. So this was a point prevalence study that was done across the facilities, and it included taking vital signs on all patients in the facility on a particular day. So if each facility had a 7-day window to do this work, and we disseminated information about how to do this to all our networks through our ECC network. For example, we had the IPOG network that was also used to disseminate information, and everyone who was involved also used all the networks that we had to disseminate information to all African countries, so those who were able to participate could participate in this study. And what we found out from this study is that critical illness, there was a high burden. So around 12.5 patients were critically ill in our wards, in our facilities, and around almost 70% or 68.6% to be specific of these critically ill patients are actually found in general wards and not in ICUs or HDUs as most people would actually think they should be found, or where they are found. And we also found that there is a high mortality. Around 21% of these critically ill patients die within our facilities in 7 days, which is compared to the non-critically ill patients who are around, the mortality was around 2.7%. So where are these, from this data, we found that most of these patients who are critically ill are actually found in general wards and not in ICUs. But we also wanted to see if is this only applicable or only found in Africa? And we had another study that was done by our colleagues from Sweden, Sri Lanka, and Malawi that showed that actually this is not unique to only Africa. It is also found in other countries. Like, for example, we can see in Malawi, in Sweden, and in Sri Lanka that also more than 80% or 9% of these patients are actually found in general wards and not ICUs. So we need to find a solution on how to provide care to these patients, and not because we are not able to have ICU beds for all the patients who are critically, and actually they do not need ICUs. So what we saw also is that most of these patients are not receiving the care that they need, this very basic care that we talked about. Around 48.4% of the patients with respiratory dysfunction were not receiving oxygen in the facilities, and around 54% of the patients with circulatory problems were receiving IV fluids or vasopressors when we did the study. Also, around 50% of the patients with low consciousness levels received any airway intervention. So half of them were not, almost half of the patients actually were not receiving the care that they needed to keep them alive in the facilities. So when you have a problem, we try to look for the solution. So for many years, we've had thoughts of what solution could be provided to these patients. Before even generating this data, we knew that we could see the problems that were happening. Now we have the data, and we have a solution that we could actually implement in our facilities. So one of the things that we need to do is to understand or to think about critical illness and how we provide care to these patients. We have to change the way we conceptualize critical illness and critical care. And we also need to have a unified approach that we use to care for this critical illness, irrespective of who they are or where they are or from which specialty they're coming from or whichever settings they are in the world, and whatever initiative that you're talking, be it an initiative for internal medicine, maybe HIV patients, hypertensive patients, or trauma patients, or mothers and children, or our surgical patients, all these patients, all the initiatives that you're talking about need to have a unified approach that they would take to take care of these patients who become critically ill at any point in their care. And this is where we came up with the concept of essential emergency and critical care, which is actually the most simple first-line form of care that critically ill patients need to receive in wherever they are in the world. So it doesn't choose the kind of gender or age or diagnosis of these patients. Whatever the diagnosis they have, this is the care that these patients will require when they become critically ill. So ECC actually defines the minimum standard. So we're not talking about the maximum things that you can do. There's so much you can do depending on your facility, but we're looking at the minimum standards of care that all critically ill patients need to receive so that they can their lives can be stabilized. And then the definitive care for their underlying conditions can be provided to these patients. So it's mostly, it is actually a concept and system innovation. We need to look at change the way our systems have been set to be able to provide this care to our patients. We don't need a lot of money to do this. So this is my next slide, looking at the complexity and the cost of providing this care. So when you're talking about essential emergency and critical care, we're talking about the most basic care that these patients need. And this can be provided anywhere these patients are presenting, from the emergency room to the operating theater, to the ICUs, or to in any ward that they are in. And these are things like triaging them, identifying that they are critically ill, providing them with IV fluids, giving them oxygen, positioning them in the right position to make sure their airway is protected. And the cost for this care is really low. It's around $14 per daily averted. And then, but when we go higher, we see that there's intermediate emergency and critical care, which costs a little bit more money, and it's more like it can be provided maybe in IHDUs and the settings like that, which consists of CPAP and vasopressors and the like. And then we have the advanced care. And we see that very few patients actually need this advanced care. And this is where we talk about ventilators and the like, and ECMOs and renal replacement therapies. This is very costly. And for us to have the highest impact in our populations, we need to make sure that we're providing this most basic, essential life-saving care to our patients. It's very cost-effective, and it's also feasible to provide in our settings. So just to finish up, I'd like to us to look at this slide and see how care or what is happening in this area of ECHO currently mostly in our countries where we're coming from post-COVID-19. We had very low quality, or we've had low quality ICUs, and the quality of care that is being provided, as we've seen in this study, more than 50% of our patients are not receiving this very basic care. So the care in our wards and care in our ICUs has really been not so of good quality. What is happening right now, there's a lot of improvement post-COVID that has been happening in ICUs, building emergency rooms, and oxygen is being also scaled up in most of their countries. But most of these initiatives, or all of them, do not speak about what we need to do in our wards to improve the care that we're providing to our patients. So it's actually, there's a danger of sucking up the care or the provision of care in our wards and really concentrating on ICUs. And then when we can do a lot of good work in ICUs and send our patients to the wards. And if they're not receiving good care in the wards, then they'll come back to us or they will die in these wards. And the vice versa. Also, we do a lot of work in theater and send our patients. We have very good facilities, but then our patients die. So what we need to do is also ensure that our wards are optimized and are able to provide this care to our patients, so that whatever work we are doing in our ICUs, in our emergency units, becomes more impactful. Because now when they go back to the wards, we are able to save their lives. We are able to keep them alive, provide them with oxygen and the IV fluids and everything that we need to give them, which is very essential, which is quite cost effective, and it is actually feasible. It can be provided by any healthcare provider that is actually found in any of the wards that we are serving. So, as a conclusion, we need to have this data that comes from our own context, from our own areas. Like in Africa now, we have data that actually can lead us to think of the solutions that are cost-effective, that are feasible, and can save many lives, which is this. So I just wanted to show you as an example of what we have done in Africa. Thank you very much.
Thank you. Thank you very much, Karima, for the insight from the African Critical Illness Outcome Study. I will invite the speakers to join me right here in front at the table, please, for a Q&A session. Thank you. Thank you very much for sharing all your knowledge and your experience in your topics. A question for John Fogarty. WFSA has been supporting efforts to improve palliative care services globally. How would the SPDI platform be used to help scale palliative care services around the world?
Thank you. That's a great question. And one that in my presentation, you may have seen how countries can use the SPDI platform to be able to define a package of services for palliative care. And many countries right now are looking at how they can scale palliative care. Many countries have no palliative care services explicitly defined for a package, or they don't even have them defined at different levels of the health system. So there's something that we're doing right now in the Eastern Mediterranean region, where we're going to be bringing together groups of countries to be able to work together to use the SPDI platform to define explicitly the palliative care services that would be delivered, where they would be delivered, what are the material resources required, and what are the health workforce requirements. I think WFSA and the membership and other partners will be key to be able to help support countries when they define a package of services for palliative care and then they go to implement it. So helping their health workforce to be trained in palliative care, making sure that the regulatory policies are in place to be able to deliver the palliative care resources, critically important.
Thank you very much, John. We have microphones and audience. Yes. Yes, thank you.
Thank you very much. Hellman Gattam neurotrauma critical care. So underlying, thank you, Karima, especially for your ASIA study. So underlying the part of the burden of disease and how we manage it, where we manage it, and how we finance it lies a very deep ethical question in terms of defining survivability. And for example, in my environment, a Glasgow coma scale of 3 with fixed dilated pupils is 99% answer. It's not 100%, it's 99%, actually 95 to 99% unsurvivable. But developing some sorts of thresholds which are really packed with controversial ethical issues is a big issue, because even the occupants of ICUs tend to be invariably relatively unsurvivable patients. So how do you tackle that? It's loaded.
Sorry, I'm not sure I got the tackling the ICU issues of ethics and oh. That's a very good question, and an ethical dilemma that we have had in many countries, including my own in ICU patients. But in general, the way we defined the critically ill patients who are salvageable are those where we see there's still room for reversibility and if care is provided. And if we see that, for example, in the brain death patients, you worked with us in Tanzania, and you've seen that we currently have no policy on how to handle brain death in our facilities, and beds are occupied by patients who have been seen to be unsalvageable, but we are not able to remove them from our ventilators or ICU beds and provide care to other patients. So it's not really right now my major area of work, but we have tried to work with our governments to come up with policies that will guide us on making these decisions for our country. But right now, what I'm mostly working on or thinking that there are a lot of patients that we can actually salvage in our wards that we are not recognizing in time and we're not providing care to in time. So coming up with solutions that can help us ensure that this happens in our wards, and also that will also help us reduce the burden of the number of patients needing ICUs and the beds getting occupied by patients who are actually salvageable, and maybe making decisions earlier on before we even put them on the ventilators that these patients are not salvageable and we should not put them on ventilators and use them for those patients who really need this care. And also, what I see also in our facilities is that sometimes we keep patients much longer than needed in ICUs just because we're not able to send them back to our wards because the wards are not functioning very well. So if we improve care in our wards, we'll be able to create more ICU beds for those who really need ICUs. And also, if we improve the way we identify patients early enough, we'll also avoid the need of making decisions later on these unsalvageable patients. Thank you.
Thank you very much. You have another question.
Rick Hanker, G4 Alliance. Thank you so much for the presentations. I know one of the challenges, and I work with Ministry of Health and collecting data related to access to anesthesia and surgical care, is trying to get a measure of the entire perioperative workforce, including nursing and other healthcare providers in the health centers. And I wonder if you have any thoughts about how we could go ahead, and I know we are trying to collect some of that workforce data, but any thoughts about that? And then also one of the things that we find that's a real difficult piece, trying to get the data from the more rural sites compared to some of the urban sites in terms of collecting that data. So any thoughts on that would be helpful.
Thank you.
Thanks, Rick. I'd perhaps start with the fundamental. We don't know who we are or what to call ourselves. The you know, we squabble about, are we one title or another title? So I think that the one thing we need to start is a globally accepted nomenclature for providers, be they anesthesia professionals or surgical professionals, because until we do that, the data is not particularly meaningful. That in itself is an interesting project for our CHESA group. It's a kind of hobby project that we're working on a structure together with Jim Campbell's group here at WHO. It won't resolve the country level nomenclature that countries choose to use informally, but what it will create is a structure that basically starts off with what is your primary, you know, training? Are you physician, nurse, other healthcare, other background? Are you trained through a certified program of some sort at a state, provincial, or national level? Are you licensed to care for patients? So that kind of structure. But ultimately, we're not going to know the answer to your question until we come up with a standard definition. And, you know, Jackie sitting next to you has been involved with us in doing a global anesthesia workforce survey. It's a real challenge. National societies who provide information only know the number of members they have. They can tell you that people who are not our members who are working in this field. Ministries of health count numbers differently. I was at a safety meeting in Japan some months ago. The Japanese Society of Anesthesiologists says there are 14,000. The Minister of Health sitting at the same table with us said, no, there are only 9,100 and whatever. So until we know who we are counting, we will never count them correctly. So it's a long-winded answer to your important question.
Thank you very much.
It's a little like the line from Alice in Wonderland, you know, words, said the Queen of Hearts or Humpty Dumpty, mean exactly what I want them to mean.
Thank you. Yes.
Hi there. I'm moderating quite a lively chat on the webinar,
Zoom.
and we have a question from Pedro Ibera, who's based in Colombia. I think some of us know Pedro. He wants to know: does the panel have examples of success stories of data collection and how they've and the impact they've had, so that we can convince ministries of health to invest in data collection?
Who would like to? Okay, Chris Dodgen. Yes, please.
Just to repeat the question, I think you said successful stories of data collection that can then drive policy at ministries of health. So in terms of the WHO registries, many people have adopted both the emergency and the trauma care registries. That, as I mentioned, provides great sort of real-time visualizations that they've been able to take back and directly affect the patient care. That has influenced overall ministries to then lead to national adoption. There are some countries that, for example, the WHO trauma registry or trauma module is the main trauma registry for the country, suggesting again that it's shown that sort of positive impact. We hope to see that in the Operative Encounter Registry that we're going to pilot this summer. Needs to be seen.
Thank you.
Sure,
You want to
I'll
share?
add to that a couple of things. So from the population level, there are a number of exercises that have been done to show that we can gather data. There have not been very many exercises that have shown after an interval of time that we've been able to improve or make a big change in that population data. So it's a very astute question. But I think there are multiple examples of using large data sets to affect change at the policy level. The unfortunate thing is that most of them are from high-income countries. So the different ways of breaking it down would be either by subspecialty, if you're trying to find subspecialty registries or large data sets within low-income countries, or sometimes we have to use the data that we have from high-income countries in a kind of data Robin Hood approach to take the data from data-rich countries and use it to understand some of the policy around implementation, and then try to use those same algorithms to understand how it might apply in low resource settings.
Thank you very much. In the audience, this will be the order, so you have in mind. He will be first, then you, and then you. Okay.
Good afternoon. My name is Abdelad Hausawi. I'm a hepatobiliary surgeon from Saudi Arabia. So a question to Professor Gelb. The outcome of a surgical patient depends on a good anesthesiologist working with a good surgeon and having good nursing staff. Unfortunately, in surgery, we have what I call the tribal approach to surgery, what I call them the anesthesiologist tribes, the surgeons tribes and the nursing tribes. And how can we move, because, you did talk about the anesthesia self-assessment tool, and I think this is very important. But if you look at the literature of high-performance teams, these teams actually train together. They work together. There's a pre and post. I haven't seen I would like to listen to anyone who's in the operating room has seen high-performance teams like surgeons, anesthesiologists, nurses working together pre, post. We just don't see that, and I'm not sure we can really take the safety to the next level if we just keep that kind of siloed approach to it. Thank you.
Abdullah, thank you very much for that pointed and appropriate question. The issue of team training absolutely is crucial. One of the initial big problems with team training is actually getting the siloed groups to agree to team training. And in my experience within our own institution, that has been one of the biggest challenges, and the biggest offenders are surgeons. But we need team training in multiple ways. We need team training in terms of the actual care delivery. And there are simulation modules out there that are focused on specific populations, trauma care, for example, cardiac arrest care. Those need to expand. But we need to build similar models that touch on more political aspects, team training in patient safety, team training in the politics of raising awareness about surgical care. We need to build teams that go to hospital administrations, regional health authorities, and ministries of health, and that speak collectively on behalf of the patient, but us as a group. And my challenge to those who would be interested in is create that simulation scenario that will bring together surgical anesthesia and nursing leaderships through a training exercise on how to speak about us in the interests of our patient, not me in the interests of my patient. In relation to your question about patient safety, one of the big aspects where we're falling down, and this came out in your very nice panel late last night, is in the implementation side. One of the things we will have as a suggestion in an editorial that'll be in the British Journal of Anesthesia in the next couple of months is that standards start including some kind of metric about implementation ease. Here's a standard of care, and this will be easy to implement in most environments. Here's a standard of care that will be very difficult to implement, because one of the challenges in implementation of safety or any other initiative is a low tolerance for it didn't work. It didn't work, so I have no interest in safety any longer. So we need to create those wins and structure it into our data tools. Here are the easy things to collect. Here are the hard pieces of data to collect.
Thank you, Adrian. Please.
Catherine Madani with Center for Global Surgery at Baylor and Association of Academic Global Surgery. Dr. Rose, your example of Mozambique is very interesting. Can you share with us, how did you build the coalitions necessary to bring everyone on board? And how did you convince or support that effort? Because we all are, to varying degrees, aware of barriers to data collection. And there's a reason that the countries are not collecting this data. So in your experience in Mozambique, what have you learned that can maybe assist the rest of us in encouraging data collection in our own environments?
Yeah, thanks for that great question. I'm going to borrow from a page of Dr. Gelb and say that I'll talk about us and our project instead of me and my project. And it's very important to acknowledge the shoulders that you're standing on when you initiate a project, especially if it's not in your birth country, which for me, Mozambique is that case. So I stepped into a scenario where there were multiple surgeons, predominantly from high-income countries, but also from low-income countries who had been working within Mozambique to do various types of surgical research, and plugging into their networks and understanding what gains and what wins they had already had was a critical part of building on those gains and then trying to chart a path for the future, navigating the landscapes of not only the politics locally, but also the network of the NGOs that are maybe outside of the ministry, as well as the research capacity that already exists within the local medical school, for example, and the interest level from the student body and the faculty body as well. And then taking that and trying to chart a path forward in collaboration with the people who are taking care of patients within the healthcare system in real time on a day-to-day basis. And I have to acknowledge the role, for example, of NIH funding to the Ministry of Health in Mozambique through the MEPI grants, the HEPI grants, and some of the funding that came through PEPFAR essentially, that was restructured at the NIH and then allowed certain surgical researchers to gain critical capacity in research methodologies that had nothing to do with me. But by plugging into what they had already accomplished, it allowed me to essentially help to create a vision, be a part of a team that could see where do we want to go from here based on international standards and what we're kind of working on here locally and what the patient needs are within our hospitals, and then move in that direction. But it's definitely a team-based approach with ministries, with academicians, local and foreign, including myself in the latter category, and developing that coalition towards common goals.
Thank you very much.
Hi, Katie Wells, the University of Vermont. I'm the Director of International Emergency Medicine. I just want to commend the panel for incredible overview of eco-care. My question is, as an emergency provider, and no offense to my hepatobiliary colleague or anesthesia colleagues, but I truly believe your outcomes in surgery and anesthesia are highly dependent upon high quality emergency care as well. And we don't talk a lot about the pre-hospital system, the emergency care system. And so I would love to throw to the panel, particularly my surgeons and anesthesia colleagues on the panel, when you're discussing the team-based approach, how do you consider including your emergency care providers, your emergency care nurses, your pre-hospital system in that team-based approach? And just very quickly, would love to point to the G4 Alliance on being so inclusive of emergency care and really working to pull emergency care into this process. So thank you very much for all the work you've done.
Thank you. Thank you very much. In order of time, I'm so sorry, but we have to start closing. And I'll go to a rapid fire round to all panelists. Please provide one final word or a small phrase that you may wish it remains in everyone's mind regarding this topic.
Gratitude. Thank you all for being here.
Gratitude.
Thank you for supporting WHO.
Thank you.
I would say integration, to the last point that was made, integrating all the elements of the team and all the things that are around us that are already happening.
Integration.
If we don't measure it, we can't improve it.
If we can measure, we can prove it.
Data has showed us 50% of our patients not receiving the essential care they need. And we are able to provide this care and save up to 1 million lives by just changing our systems and to provide this care in an efficient way.
We can only do it together.
Thank you very much. Thank you very much to our panelists. We heard yesterday, data is life. And today we heard talk about how do we work for our patient instead of my work for my patient. So today's session highlighted the critical role of data and standards in advancing patient safety and universal health coverage. We've seen how innovative tools can transform patient safety to ensure safe and effective care for all patients. And our discussion emphasized the power of collaboration in using data for change. So that's a call to build partnerships that enhance surgical and anesthesia care, especially in low resource settings. So maybe we can reflect on how today's metrics and standards can be applied in your work, my work, for our patient. Together, we can turn data into strategies that improve patient safety and promote health quality. Heartfelt gratitude to our panelists, to our audience in person and virtual, to CHESA and to WFSA for sponsoring. Thank you all for your valuable participation. We would be honored if you can join us for the networking lunch downstairs located on the left in the Fontana room. Thank you very much. Muchas gracias.